So hello and good afternoon, everyone. So welcome today to the session of the Teletrauma Grand Rounds. And today we have Dr. Abbasali Badami, who is a critical care and trauma fellow at Ryder Trauma Center at the Jackson Health System in Miami. So he will be presenting today a case titled A Bad Day with Good Luck, which is a very interesting title, I think, and I'm very excited to see what the case holds. So over to you, Dr. Badami.
Thank you so much, Dr. Kumar. Good afternoon, everyone, or good morning, good evening, wherever you guys are. So we'll be discussing this very interesting case. It's an unusual case, a rare case, but pretty interesting. So the objectives of this case are basically review and evaluate the mechanism of injury, the pattern of injury, review in detail the diagnostic studies that could be performed when we see these kind of injuries, and I also identify the management options for patients presenting with these injuries. Sorry, I'm just going to fix my video screen. So this was a 42-year-old gentleman that presented after being stabbed in the left anterior chest and left paraspinal upper back. He was stabbed with a knife during a conflict at home. A little bit backstory: he was released the same day from prison. He was incarcerated, released the same day. He went back home to see his wife, and basically found her with another person, and who basically they ended up in an altercation, and the other person, third person, stabbed him in the left anterior chest and the back. He was when he came in, he actually was brought in by EMS. He reported constant pain at the stab site in the back, denied any other complaints. No past medical, past surgical history, no allergies, no medications, denied any social history. So on primary survey, he was protecting his airway. He had bilateral breath sounds. He was saturating above 95% on room air. His initial vitals were a blood pressure of 119/62 and a heart rate of 108. He was a GCS of 15, had grossly intact sensory motor functions on upper and lower extremity. On exposure, he had two wounds. One was in the left anterior chest, kind of inferior to the left clavicle on the lateral aspect, around 4-centimeter wound. That was bleeding, so we just put in some pressure dressing on and controlled that. And the next wound was this. It was a stab wound to the back with a retained knife in the upper back. As you can see, the trajectory of this knife was inferior medial towards the midline. So question, what would you do next?
Thank you, Dr. Badami. Dr. Ribeiro, are you here? Are you with us? Okay, I guess not. So I'll move on.
Yeah.
Oh, okay. You're here. Okay. Would you like to make your comments first?
Yeah, sure. Well, this is a very challenging case. Congratulations. This is the kind of case you kind of say, oh my God, what I'm going to do now. But I think as soon as the patient, I'm assuming the patient is stable and clinically doing well, besides the fact to have a stuck object in the back. So you might try to get some image for this patient, at least an X-ray, to get a better idea how big is this knife, the direction of the blade, in order to plan your treatment. But you have the in favor the fact that the patient is stable. So I would at least start with an X-ray to have a better idea of what we're talking about here.
Thank you, Dr. Ribeiro. Dr. Kasim, would you like to make your comments next?
Well, the moral of the story is, when you've been incarcerated, when you go back home, be aware there might be snakes.
That's why the title, Dr. Kasim.
Make a phone call first.
So, well, he's stable. He's relatively stable, and he's young. He's probably compensated, and I think you should do a good physical examination, whereby you get bilateral blood pressures on, and check everything, and to make sure you haven't missed anything. and then and also look at the anterior chest. Is it anywhere in the box? If the anterior stab wound is near the box, it will take precedence before you tackle the posterior wound. So after having checked out thoroughly, I agree with the previous commentator that some type of imaging would be very, very useful in planning what you want to do. The one thing that I will not do is to extricate that stab knife from the back unless you are in the operating room and ready to go. So this is going to be an interesting case to see what comes out after the imaging is done. Thank you.
I'm gonna ask Dr. Untrak, what do you do in the same situation, talking about being in the remote location like you used to be in a hospital where you don't have a support? So
well,
different management
right.
there. Then after that, Dr. Hodgman in Boston.
Yeah. So, well, first of all, this gentleman should look at it a little bit optimistically. Number one, he's sitting up, but number two, in this case, he's the victim. So he's made progress after, I don't know how long he spent in jail, but for once, he's not the perpetrator. So there you go. So in this case, I would, first of all, be interested, be sure he's got the pulses in the left arm, and because that's the anterior stab wound, I would put the IV in the right arm, and the second IV, if he needs it, probably later on in the groin. And in Haiti, we used to get things like this, or gunshots. If people walk in, they got multiple holes in the back, but they can walk right up to the X-ray plate in the X-ray department. You can take PA and lateral films, And in this case, I would probably do it portably. I would do a PA, yes, in this case, PA, and a left lateral, and prepare some blood. And then I would give him a little bit of fluid because of his tachycardia. And then if he remains stable, I would, we couldn't do this in the remote location, but I would do in Miami, I would do a CT scan either in the left lateral decubitus position, the bad side down, or probably not prone, because you'd have to protect his airway first before you put him in that position. And but in a remote location, we'd have the two X-rays, see where it went. Apparently, it did not penetrate the aorta to the left of the spine. So, I think in this case, seeing where it went, if it did go in the left chest, we would do a posterolateral thoracotomy into the left chest and remove the knife under direct vision, see where it is in the chest. But in this case, you can actually do a CT scan and see where it is, and possibly avoid the thoracotomy, or perhaps utilize thoracoscopy.
Thank you, Dr. Untrak. Dr. Hodgman, would you like to make your comments next?
Well, first, I would not let him lay down flat. This case, I would, as it was mentioned before, I would get just plain films to get a better idea where this thing is. And he's stable enough, I would probably go for a CT, because that would allow me to better plan the surgical approach. Yes, it depends on what it is. It's most likely than not, this would be a left posterolateral thoracotomy for approach. But I have seen places, it was mentioned before, not to remove the knife. I think Dr. Kasim mentioned, that's for sure. I have seen cases like this where it went through and through in the aorta, and it's occluding the aorta, so you cannot touch it. But if it's involving the aortic arch, which is still possible, this patient will have to go into cardiopulmonary bypass. So there are many unknowns here. If he starts bleeding, yes, it's a left anterolateral thoracotomy and good luck. But if you have time, CT scan to plan the surgical approach. Thank you.
Thank you, Dr. Hodgman. Dr. Frisby, would you like to add any comments?
Well, I appreciate all the comments. I think that's true. If you're going to do a CT, you better not lay him down unless you got a hole in the hole in the tray. But I think, you know, it's odd. He's still holding on to his vital signs. I think Dr. Hoykman might be right. I think he may be occluding something that if you remove that foreign object, he's going to crash on you. So I think maybe a left thoracotomy might not be such a bad idea unless he's in the box. As far as the social comment about Vic or Perp, it's just karma. That's all that is. So those are the only things I have.
Thank you, Dr. Frisbee. Dr. Torregiani, I'm sorry if I'm saying your name wrong. Would you like to make any comments?
Oh, yes. I would definitely order a CT scan to better plan the surgical approach of this patient. Thank you very much.
Thank you. Okay, over to you, Dr. Badami, to continue the case.
All right. Okay, so while we were reading, like, you know, the X-rays there, and like Dr. Kasim mentioned, we performed a thorough examination since he was holding his vitals and he was borderline tachycardic. So he's ANO times 3 cardiovascular, he was regular rate and rhythm. So chest wall, there was a question about where was the anterior chest wall wound, whether it was in the box. So the wound was in the anterior chest, I would say a couple of centimeters below the left clavicle on the lateral aspects by the shoulder, actually. So it wasn't anywhere near the box. And as mentioned before, it was oozy and we had applied a pressure dressing initially, and there was no evidence of any expanding hematoma out there. There was no signs of other injuries or other stab wounds on the back besides this one stab wound with a knife sticking out. Abdomen was soft, non-tender, non-distended. On motor, he had gross motor and sensory function in upper and lower extremity. The other comment that was mentioned was about his vascular exam in bilateral upper extremity, and he had palpable distal pulses. We also checked the blood pressure. It was pretty similar in bilateral upper extremity, and also distal pulses in lower extremity. So I think I'm going to skip this slide and go on to the next slide where we discussed what is the next imaging, and I think some people alluded to X-rays, fast CT scan. So since the ultrasound was right there, we performed a fast. And as you can see, this is right and left lung slidings. And this is the cardiac window. Again, not great images, but like on actual, and the actual machine did not see any pericardial fluid. So again, just in the interest of time, because there's you know, quite a bit of interesting things forward, I'm going to move forward. The other imaging modalities that were mentioned was getting an X-ray. So this was his X-ray, which showed this was a P view, which showed approximately 8 inch of serrated blade crossing the midline. And also got a lateral film, as Dr. Antract had mentioned, which showed the tip terminating dorsal to the anterior surface of the vertebrae. Again, during this entire process, getting this imaging and doing the fast, he remained hemodynamically pretty much the same. So what would be the next step at this point in time?
Thank you, Dr. Badami. Dr. Frisbee, would you like to make your comments first?
No. Well, you know, that's a rather intimidating looking knife. The length of it is anyway. However, yeah, that one's intimidating. But if you get a lateral, not quite so much, but it's across the midline. And once it crosses the midline, I think you're obligated. Now, I think you need to sit back and think for a moment about what the approach is going to be. If you do the median sternotomy, you may be limited. This is in the back, so I probably would do a left thoracotomy at this point. If and when I get ready to open this patient, you're gonna have to open him. So to get that knife out, and I would not just arbitrarily remove it. We don't know what it's pressing against. So that's my only comment.
Perfect. Thank you, Dr. Frisby. Dr. Ajman, would you like to make your comments next?
Sure. Sorry. Okay, I have a trauma in 10 minutes. So I would do a CT scan. Just, yeah, this patient needs to go to the OR. I completely agree with Dr. Frisby. It will be a posterolateral thoracotomy. This is not, the injuries here is the aorta and the esophagus. That would be my major concerns. I would do a CT scan, maybe even a swallow to evaluate the esophagus, but these are the two injuries that need to be ruled out first. And after that, go to the OR. I'm pretty sure that the intercostal is going to bleed because probably cuts one of the ribs and the intercostal is cut. So there is no way to do this without going to the OR. But I would get a CT maybe just to have documentation of an interesting case. But this patient needs to go to the OR. Thank you.
Thank you, Dr. Ajman. Dr. Untrek, would you like to make your comments?
Yeah, I think you got to do something before the knife just falls out. I mean, if you put them on his side, you may have to pick it up off the floor. But if this were Haiti again, with this X-ray, I think looking at it, I'm guessing that again, this guy was lucky. He was the victim here, and it looks horrible, but it looks like the knife went through the subcutaneous tissues, the muscles of the chest wall, and into the right chest along the spine. So missed everything. Had it been a little bit longer, and it must have been a left-handed. I don't know how he did that. A left-handed assailant that struck him that way into the right side. But had it gone on the other direction, well, that explains why he's in such good shape. And there's no blood filling up in the left chest. The costophrenic angle looks pretty sharp. But in the setting in Miami, I would do a CT. I agree with everyone else. But if I were in Haiti, I would probably guess that it's in the right chest and go first in the right chest, and then see if it's there, and then have somebody pull it out while watching inside the chest. And had I gone on the right chest, in the left chest in Haiti, I would look around and say, look, there's no knife here, what's going on, whatever. But I think looking at that X-ray, it's probably going to be on the right side, I'm guessing.
Thank you, Dr. Untrek. Dr. Kasim, would you like to make your comments?
A couple of things. There's quite a bit of magnification on X-rays when you look at the stab wound here. So take that into consideration. Second, when you do deploy the CT scan, I think it will be worthwhile to do a CT with contrast, so you get to see the vessels as they light up, and you have a rough idea what he has missed. Because I'm pretty sure if this would have gone into the thoracic aorta, he would be dead by now. I don't think he would make it. So, and once in a while, you see something like this, it misses everything. And that is rare. But it does happen. I think in this particular conference, somebody showed a case like this where somebody stabbed somebody and it missed the pulmonary vessels and the between the vein and the artery. It went between that. It missed everything. So it could happen too. So that doesn't happen very often, but you do not want to take a chance like that with somebody's life. I think I would just go for broke here. I would do a left posterolateral thoracotomy under direct vision. I can hopefully see the knife where it's going and then pull it out and then repair the damage. Be prepared to have various vascular cams available in case that you were wrong. Thank you.
Thank you, Dr. Kasim. Dr. Torrigiani, would you like to add anything or make any other comments?
Yes, if we don't have the CT scan available and we decide to take this patient immediately to the OR, I would start with left thoracotomy, but I will be ready to convert that incision into a clamshell incision. That will be my plan, I guess, but it's very difficult. Thank you.
Thank you. Dr. Ribeiro, are you still with us? Would you like to make any comments?
Well, yeah, I have to agree with the previous colleagues. I think a CT scan will give a very good plan option, so you can really decide which way is going to be the best one for you to approach the patient. And also agree with Horacio that in case you don't have the CT scan, this patient needs to be prepared for a clamshell in case you need to go for both sides of the chest. But I think CT scan will be a very good tool for us, so we can really actually understand, the track and make the further plan for the best incision to approach this kind of injury. I would tell you that probably I would try in our hospital nowadays, after the CT scan, depending on which kind of injury you have, go with thoracoscopy. But let's see what's we're gonna have here.
Thank you, Dr. Ribeiro. Dr. Badami, back to you to continue the case.
Thank you. So great comments by the panelist. So as the consensus was, we ended up taking the patient for a CT scan. And as Dr. Kasim mentioned, we took into consideration the fact that there would be possibility of vessel injury, and patient ended up getting a CTA of the chest. So this is what we saw on the CT scan. You can see the knife coming in lower again. Just go back a little bit. Right there, posteriorly in the spine and entering into the right pleura right there. Tip. And this is the lung window. Again, coming in and entering into the right side of the chest from the left. And also noted was a very, very very small apical pneumothorax that was called by radiology, and we saw it as well in review of CT scan. And I think it's important to mention out here, as the panelist previously described, the important consideration of making sure that this patient was transported carefully without the knife moving or falling out, as Dr. Unkart mentioned, and making sure that even when we place the patient on the CT table, there's not much movement. The CT scan was done in a prone position, and making sure that there's the knife stays still, and also educating the patient at constant intervals to not move. Again, because this is Miami and this is Ryder, we were able to be a little bit fancy and get some recons on the CT scan, where they basically subtract the surrounding tissue and are able to give you the trajectory of the knife itself. And as you can see in this image, going from the left into the right chest, and violating the pleura on the right side. So the next steps.
Okay, thank you, Dr. Badami. Dr. Untrak, would you like to make your comments first?
Yeah, so if I saw the image correctly, the knife did not penetrate the left pleural cavity, and it stayed in the chest wall, crossed the line, then entered. And there was something in one of your slides about entering the spinal canal at T8, but it was paraspinal. It was really, it didn't affect the spine, the spinal cord. It was really outside the extra vertebral, but at T8 level. So in this case, I think what I would do is the CT helped plan well. And, because this patient came sitting up and talking everything, that it would have to be something like this. But I would take him to the OR for thoracoscopy in this case, because it looks like that there's really nothing in that area. There's no vitals, really nothing there, except you have the azygos arch, and but I would put thoracoscopes in the left lateral decubitus position, and maybe even put a double lumen tube in, deflate that lung so you can see the knife rather well, and then have it withdrawn under direct vision. And if he gets a tension pneumothorax, you can put a chest tube in or do what you need to do. But that, in this case, that's what I would do. Again, in Haiti, I would do a right thoracotomy and withdraw the knife under direct vision.
Thank you, Dr. Amtrak. Dr. Ajman, would you like to make your comments next?
This reminds me, when I was at San Francisco General, this is probably a very bad guy. When I was at San Francisco General, they have this Tranke's law printed on the wall. Your chance of survival after trauma is directly proportional to your social worth. So this probably the reason he survived was nothing. The spine could have been injured, the aorta, everything, and they miss everything. So the only issue you have here is probably fracture of the posterior elements of the spine. So I would probably take him to the OR, put in supine, and take it out and see what happens. I expect some bleeding from some of the structures, but I don't think you have too much here. I expected much worse, I had to say. The CT scan was disappointing. Thank you.
Thank you, Dr. Ajman. Dr. Kasim, would you like to make your comments next?
I like the wisdom of Dr. Hoshman. I think you try to do the best with the least injury to the patient who is already injured bad. And you have all the knowledge now what it is going to happen. And so now you rely on a little bit of luck. So what I probably would do, I think I would just put a chest tube on the right side and pull the knife out in the operating room under direct supervision, having all the equipment, everything ready, anesthesia ready in case he crashes, and remove the knife and see what happens. That's what I would do.
Thank you, Dr. Kasim. Dr. Ribeiro, would you like to make your comments?
Yeah, I think now with this scenario, I would try to, do a thoracoscopy right side, remove the knife under direct vision, and that probably will be it.
Thank you, Dr. Ribeiro. Dr. Tarigiani, would you like to add anything or make any other comments?
No, I totally agree with thoracoscopy. Now that we have the CT scan and we are in a better situation, we are calm down now. Thanks.
Perfect. Thank you.
Just one comment I just realized. How do you intubate this patient to do any surgical procedure? Just came to, how are you going to put a supine, intubate on the side? How do you do this? My apologies, I just got a trauma, I need to leave, sorry. I will miss the answer, bye.
Okay, perfect. Dr. Amtrak, would you like to take that question?
Well, it's like the case of before Dr. Hochman leaves, the case 2 weeks ago where they had this patient that was restrained in a machine, the combine, and they did it laterally. In this case, they did a cricothyroidotomy, but they could probably intubate him with over a bronchoscope or whatever. But anyway.
Dr. Frisbee, would you like to add any comments or answer this question, whichever you want?
I don't want to answer the question, no, but I will comment. I consider all of the, I think you're right that you probably could do a thoracoscopy if you've got anybody there who knows how to do it. Some of us, I just don't know how to do that. I've never done one. I think Dr. Hoyman's right. I think I would just gently remove the knife, and during that period, I would hold my breath until everybody in the OR to stand by, because I don't know what's going to happen at this point. So that's my only comment.
Maya, I'm sorry I missed the first part. I was in the OR, but I heard there's a question about intubation. Was the position difficult? What was the reason that you couldn't do a standard intubation in this patient?
Dr. Badami, would you want to take that?
Yeah, Dr. Varone. So the patient had a stab wound to the back with a knife sticking out from the back.
Okay, so you can intubate him in a lateral position. That's not a problem. You can do rapid sequence and intubate them on the side. We do that sometimes in ortho cases when you're going under regional and the patient starts, and the regional wears off. We intubate patients in a lateral position. It's not that much different.
Okay. Can I go ahead, Dr. Kumar?
Sure. Dr. Ratan, I know you joined late, but would you like to add anything? Do you have any comments?
Yeah, hi. Hello, everyone. Sorry for joining late. I had some traumas. I was with Dr. Badami during this case. Yeah, in addition to the lateral intubation, one of the other things that we had discussed before we came up with our plan, which didn't require intubation before, was one of the other things that we've done is that we've taken 2 OR beds and placed them side by side in the operating room, and then have the gap in between them be where the blade is. You don't really need to get that fancy for intubation. As Dr. Varon said, our chief of trauma anesthesia said that the lateral intubation is fine. But if you're operating, for example, if the knife tip looked like it was going anterior to the anterior aspect of the spine, and you're concerned about a zone 1 injury or thoracic vessel injury, and you need the patient supine to access your chest or abdomen, we would put 2 OR tables together and then have the hilt of the knife in between the gap, and then we could get a proper supine positioning so that we can get adequate exposure. But I think that yeah, and then there was also a comment in the chat about intubating before CT. This guy was particularly cooperative and was able to follow instructions and totally wide awake. He practically walked from the ambulance stretcher to the trauma stretcher if we didn't stop him. So we felt like it was not necessary, but obviously if we had any concern during movement or transport anywhere, we would absolutely intubate him first.
Thank you so much, Dr. Ratan. I'm going to give it back to Dr. Badami to continue.
Okay, so great points brought up, and as Dr. Varone mentioned, the patient was taken to the operating room. We discussed the case before moving to the operating room with our neurosurgery colleagues because there was a concern that it did violate the epidural space. It did not penetrate the dura. So we had them with us in the operating room. The patient was intubated in the right lateral decubitus position and then was placed prone. Neuromonitoring leads were placed with concerns to evaluate the motor and sensory function throughout intra-op period. Since there was a small occult right-sided pneumothorax, as Dr. Kasim had mentioned, we did put a right-sided pigtail prior to the neurosurgery folks beginning their procedure, which drained about 500 and then slowed down. And subsequently, the hilt, entry site, and surgical field were prepped. And as you can see in the picture, the knife handle was itself draped with IOBAN. And this is the incision that our neurosurgery colleagues made. And you can see the knife entering the epidural space. It did not violate the dura, which we'll see in subsequent slide. The image below is actually was a learning experience for me as well, knowing it was fascinating to see the neuro motor and sensory monitoring that they performed intraoperatively to make sure that the patient does not lose function or is seen when, if at all, it happens. So the neurosurgeons ended up doing a T8 laminectomy. Nerves were seen to be freely mobile, with CSF briskly flowing around that side. There was no signs of any intradural transection. As you can see in the image, they placed a temporary duropraxy. They basically put in a stitch in the dura to have some traction on it and visualization. And then subsequently, the dural incision was extended caudally and cranially towards to get some more room along the cranial and caudal direction of the knife. And then subsequently, once they had good exposure, decided to remove the knife carefully with downward pressure to lever the blade away from the cord, and caudal pressure so that it does not catch the serrated edge of the cord. And as you'll see in this video, so you can see the epidural space, and I don't know if you were able to see, but there was some air bubbling in that space as soon as the knife came out. And that was our initial concern and the reason to place the right-sided pigtail, because it was seen on the CT scan that it did violate the right-sided pleura. Sorry. This video basically shows after removal of the knife, you can see some air bubbling right here, and also the U-shaped defect that was created by the knife. During this entire time, the neuromuscular leads were on, and there was no change in the motor and sensory graph on the leads. The air was basically, seen in this cavity, which was what we did for that was basically increase the suction on the pigtail catheter to 40 temporarily, and that would seem to resolve the air leak that was seen to be coming from this cavity. And the defect was then repaired by our neurosurgery colleagues using 5-0 non-absorbable sutures, and confirmed that there was no subsequent leak with the Valsalva. They also left a JP drain. The patient was subsequently placed in supine position, and the anterior thoracic wound was, the chest wall wound was irrigated. The hemostasis was ensured. It did have some tunneling, but there was no major vessel injuries. We subsequently were able to close that wound. This was the object that was retrieved, the knife. The patient was extubated immediately post-op and was returned to the surgical ICU. He was seen to have motor and sensory function post-op. The pigtail catheter was removed on post-op day 2, and subsequently the operative drain was also removed. During this time, important to mention, the patient also remained on antibiotics for meningitis prophylaxis for 3 days, and the patient was discharged home on post-operative day 4. He was seen 2 weeks later in the ED. He presented to the ED because of complaints of some burn in his hand, and was seen that time. At that time, the wounds were looked to be appearing and healing well, and the staples were removed, and continued to have intact motor and sensory function. So that's the end of the case. Thoughts?
Thank you, Dr. Badami. It was a really interesting case. Dr. Ribeiro, would you like to make your final comments first?
Oh, wow. Very, very well done. Very nice case. Very interesting. Surprisingly, the tract of the blade was kind of avoiding all the vital structures and the column and the cord. So very well done, very nice. Thank you for sharing. We always learn. Thank you so much.
Thank you, Dr. Ribeiro. Dr. Kasim, would you like to make final comments? You're muted, but did you say no? I think we lost him, but Dr. Antrak, would you like to make your final comments?
Yes, great case. So just to clarify, so the knife went to the right of the spinous process, and then it fractured through the lamina into the epidural space with the tip in the epidural space, or through the pleura on the right side.
So it missed the cord, and it went just a little bit, like probably a few millimeters above the cord, through the spine into the right pleura. So there was a fracture of that area, and then into
through
the
so
yeah.
Yeah, so it fractured the lamina and then came through the other sides. So yeah, very lucky, and maybe this was kind of like his orientation back. I don't know how long he was in jail or prison, but back into society, and I think from now on it's only up from there. So great case, really, and so the CT was instrumental in the reading and having the neurosurgeon there and the positioning and yeah, that's and in a remote location. I don't know what would have happened either side, right or left chest. Maybe you would have seen the blade and removed it, and maybe been lucky, but beautifully done. Very unusual case.
Thank you, Dr. Antrak. Dr. Frisby, would you like to make final comments?
Yeah, go back to the picture. No, yeah. Tell me what that line is in the midline there, above and below the incision site.
Are you? So this is the
No, not that. The skin, on the skin.
Oh, this one?
Yeah.
Oh, that's just the line that the neurosurgeons drew to mark the midline of the spine.
I thought he was a current.
And then
I thought
made
he
an
was
incision out there.
Oh, I thought he was a veteran. Okay. That's all I have. It's a very good case. Excellent. Very nicely done.
Thank you, Dr. Frisby. Dr. Ratan, do you have any final comments?
Yeah, I guess better lucky than good here. Yeah, we definitely, as my other colleagues have said here, this case was only possible because of the ability to do the CT. I think that if we didn't have that, I'd be doing what they did, or if I was in an austere setting, I would definitely be doing a different approach to rule out thoracic vascular injury. But yeah, it was wild. When like the neurosurgeons are losing their mind over a knife sitting on top of the spinal cord without actually injuring the spinal cord, that it's a sort of a big deal. And it felt like that for us too. I can't say that I've ever seen something in between the dura and the spinal cord and have no neurological deficit. So yeah, that was his lucky day. He should start playing the lottery, I think. But yeah, we got lucky and we're able to use the resources available to us to have this good outcome, I think.
Thank you so much, Dr. Ratan. Would anybody else like to make any final comments about the case? Dr. Martos, would you like to make the final comments?
Yes. So I made a case from Dr. Abbas, Dr. Ruiz. Congratulations. I would like to mention here you have for the first time a participation from Abu Dhabi here. Dr. Marcelo Ribeiro used to be in Brazil, now is chief of trauma over there. Thanks for connecting, Marcelo. To expand it to another country or next.
Thank you very much.
Yeah, so Patricia, I need to update the number of countries that you reach with these meetings that has been going for 12 years already. And also, I would like to invite everybody once again to go to the Pan American Trauma Society meeting. They're going to be happening in 2 weeks in Cartagena. You still can go there. It's going to be a great meeting. We're going to have pre-congress course on the 31st of October, and the meeting from 1 to 4, November 1 to 4 in Cartagena. Looking forward to meet many of